Professor of Oncology from Edinburgh Cancer Research Centre, University of Edinburgh, United Kingdom. Professor David Cameron will deliver a talk about how genomic profiling may affect therapeutic decision in breast cancer. So, welcome, Professor.
Thank you very much. It's an honor to be here and to be invited. And of course, I want to thank Professor Al-Ghazali as well for the invitation. Now, I will try and talk about the way in which we want to use genomic signatures to address real clinical questions. And just, of course, to think, why do we want to use genomics? Well, we just have to remember that cancer is fundamentally a disease of acquired genetic changes or an acquired genetic disease. It is the changes in the genes in the cancer which give rise to all the subsequent proteins, tyrosine kinases, etc., which alter the behavior. Now, to my mind, thinking as a clinician, there are really two questions which I would like genomics to solve for me, and I'm only going to address one of them. The first is, in the adjuvant setting, in early disease, which of our patients are going to relapse and which ones are not? Because if we knew which patients would never relapse, I, as a medical oncologist, would have less work to do. The other equally important question, but to date more difficult to give you an answer, is the question as to which cancers will respond or benefit to which particular treatments. And that is the area where I'm afraid I think we have less data coming through from the very extensive research in genomics than most of us would like. So I therefore will, to make this simpler, will simply address the first question: how can we use our current genomic tests and understanding to think about which patients have higher and lower risks of recurrence? But ultimately, we would all like genomics to address the second question. That will probably be in a few years' time, I suspect. So you'll be very familiar with these kind of diagrams. You don't need to read the detail because this is simply telling a story that we've moved from a world of breast cancer being one, perhaps two diseases, if you think of ER positive and ER negative, to a world where we now recognize that breast cancer is not one or two diseases, it's many diseases. And even within the triple negative category, we had a very clear reminder this morning that that is not one disease. And within triple negative, we have subgroups. And genomics has been one of the powerful tools to help us understand at a molecular level that cancers are not all the same. And then, of course, people have correlated those genomic changes and observations with clinical outcomes. And there are many tools and many labs that have done excellent work in this area. But we're now beginning to be reminded of something that, again, as clinicians, we've always been aware of. Even if your molecular or genomic signature says this cancer sits in this little group, not every cancer cell in that patient has identical genomic changes. There is a heterogeneity of different kinds of breast cancer, and within each patient, there will be a heterogeneity of the actual molecular changes in each cancer cell. And that latter aspect simply makes the story more complicated, and I'm not particularly going to go there this morning. What I want to try and do is to think about an individual patient. In Pierfranco Conte's talk this morning, we had an important question from the audience about how to treat a 65-year-old woman. Well, I'm deliberately going to look at a younger age group, in part because I understand that breast cancer in younger women is more prevalent in the Middle East than in Europe and America, where many of the data come from. Now, this I don't think is very controversial. I think most of us as oncologists seeing a 33-year-old woman with an 8-centimeter ductal invasive carcinoma, 11 involved nodes, grade 3, triple negative, high proliferation. Who is not going to offer that woman chemotherapy? Even if we realize that after the best chemotherapy, whatever it happens to be, she is still left with a significant risk of recurrence. She does not yet need genomics to tell us to give chemotherapy. She needs genomics to tell us which the best chemo is, but we don't have an answer. The question I want to look at is the more problematic, but actually more common problem. The woman is a little older, and her cancer is considerably lower risk. It's 2 centimetres. It's node negative. It's grade 2. It's ER/PR positive, but not the strongest. 6 out of 8 and 5 out of 8. It's HER2 negative in your local laboratory, and your pathologist tells you her Ki-67 score is 17%. Do we give a chemotherapy, followed by hormone therapy, or do we simply treat her with hormone therapy alone? Recognizing that for her, the actual numerical benefit of chemotherapy, the number of women like this who would be cured by adding chemotherapy, is small because most of these women will not relapse. And yet for the woman who would relapse without chemo, giving chemotherapy becomes important. And really I want to frame my talk around this kind of patient. I can say this because the pathologists are meeting next door. None of us have perfect pathologists. None of the pathology reports we get are perfect. And that's not our pathologist's fault, it's because the techniques are not perfect. And part of why I think we want to use genomics is actually to address imperfections in the results we get back from pathologists. So it's not just the pathologists in terms of the IHC scores that matter. Our surgeons do sentinel nodes. We now trust sentinel nodes because almost all the time a sentinel node negative patient has no disease in the axilla. But it's not perfect. Grading. Well, we have a category score of 1, 2, or 3, but there are those, and I will remind you of some data, who actually don't really believe in grade 2. They think grade 2 cancers are a mixture of grade 1s and grade 3s. ER/PR. Many countries have quality assurance programs to make sure that one lab's result is most of the time the same as another lab's result. But that's not true everywhere. Can you actually trust the score? What if it was not 6 out of 8, but 0? Suddenly we go from a hormone sensitive to a triple negative patient. That would influence our decision making. HER2 is not perfect. Those of you who've taken part in the big multinational trials and have taken a sample from your own lab, which your pathologist says is positive, and it comes back from Castle and they say, sorry, we think this is HER2 negative. We don't get everything 100% right. And Beppe Viale could give you a fantastic talk about the challenges of getting pathologists to measure Ki-67 reproducibly. They can't even always agree which bit of the cancer to look at. So we think we know the answer when our pathologist gives us a report, but actually I'm not sure we always do. So from the ALSO trial, looking at the European and US central laboratories, 21% discordance for the ER score in labs sending their data in and their samples in from the local pathology lab to the central laboratory. For PGR, it's higher. And for HER2, depending whether it's IHC or FISH, between 10 and 20% discordance. And that's not necessarily because your local lab is wrong. The central lab may look at a subtly different bit of the cancer, and that's the heterogeneity creeping in. The US central laboratory, interestingly, the ER/PR scores were slightly better, but the HER2 ones were worse. That's not saying one or other side of the Atlantic is better. It's a true global problem. You do not get 100% reproducibility. So how much confidence can you place either on your local laboratory or on the central one? And it matters. So these are data from Big 198, comparing those in the solid line, who are positive in the local laboratory for hormone receptor results, but negative centrally, and in the dotted line, those who are positive locally and centrally. A huge difference in outcome. It matters to get it right, but it's not easy. And I'm sorry, it's not even as simple as what your pathologist does. It seems to also matter what's happened to the specimen before they get to the pathologist. And this is an interesting study showing that the day of the week in which the surgeon removes the tumour alters the likelihood of the cancer being scored hormone receptor negative. Okay, we want a very simple answer from what is a very complicated problem, which is getting reproducible, precise measurements of what's happening in a cancer and turning it into something that I can use in the clinic the next day. The thing to remember, of course, is that when we measure hormone receptors, what we're really interested in is not whether, in fact, the protein is in the cancer, but what it tells us about what the cancer does. Does that cancer have intact signaling pathways for hormone receptors which would allow us to infer behavior in the patient? Behavior either in terms of risk of recurrence or sensitivity to hormones. And the group, in a way, that caused the problem are those who have the protein in the cancer, so your pathologist is correct to say it's hormone receptor positive, but the cancer completely ignores the presence of the hormone, it doesn't change the biology, and it doesn't change drug sensitivity. One of the reasons that gene expressions or genomics comes in is genomics helps you understand not just what's there, but actually what's happening. And you can identify a group of cancers who may have the hormone receptor ER present, but it's non-functional. And genomics, not for the ESR, the ER gene, but for other genes that are transcribed in response to ligands binding with ER, if they are absent, you have a signal of a present receptor, but it's doing nothing. Going back to the grade, this is data from Christos Sotirio, who's worked on this. These are microarray heat maps looking at grade 1, grade 2, and grade 3 breast cancers. And you can see in the middle, the grade 2 group, between the thin red line and the thicker red line, that actually the grade 2 cancers appear to be a mixture of lots of green, which is essentially grade 1, and those which have a higher red score, more upregulated genes, which are probably more like grade 3. And from this has come out the genomic grade index, which essentially splits breast cancer into genomic grade 1 and genomic grade 3, arguing that there isn't really a separate biologically meaningful thing called grade 2. It's simply a mixture of two other grades. And the data that support that come from this analysis here. So on the left, you've got patients who had histological grade 1. And in green, you see those who had histological grade 1 and genomic grade 1. They do pretty well. In the red on the left-hand Kaplan-Meier are the smaller numbers of patients who had a histological grade 1, but actually genomically it was grade 3. And guess what? Their outcome is poorer, because the genomic grade assessment gave you a better representation of what's happening in that patient. Over on the right, you see the converse. The red is the genomic grade 3 and histological grade 3. And then in green, patients who were histological grade 3, but actually genomically grade 1. And they do, in fact, a little bit better. And then the histological grade 2 group in the middle splits very nicely. Genomic grade 1 in green, who do pretty well, and genomic grade 3, who do pretty badly. So these data do suggest that maybe grade 2 is a mixture rather than a separate entity. And that's why I chose a woman with a grade 2 cancer. Because I don't know that being told it's grade 2 tells me whether she's in the good, the green group, or the bad, red group. And so sometimes we err to treat to avoid undertreating. But it's not really the pathologist's fault. I think they do an amazing job. This is a bone marrow aspirate from which a pathologist can tell me my patient has got metastatic breast cancer and probably tell me her ER status. And look how few cells they have to look at. And that's a tiny proportion of all the cancer. So there are sampling issues. What bit of the cancer does the surgeon give the pathologist? Variation in laboratory assays. And we want simple answers. I want to know, do I give hormones? I want to know, is it ER positive or negative? I want to know, do I give Herceptin? Is it HER2 positive or negative? And these are biological continua. It's cancer. It's complex. It's not a simple thing that we're trying to measure. And even if we look at ER, these are both hormone receptor positive breast cancers. One is very strongly positive. The one on the left represents the patient I picked, where it's not so strongly positive. And yet we want a simple answer to take to the clinic. So let's come back to this patient. What do we actually know about her? Probably not much. Other than the fact she's young, she's got a 2 centimetre node-negative breast cancer. And our pathologist has given their best attempt to answer our questions. Now, commercially, there are 4 assays available using genomic signatures, genomic processing, to give us answers. And the important thing is probably the bit in the middle in blue, which I'll read to you. So if the mammoprint has an indication in women under 60, so the 65-year-old patient that was asked about earlier this morning, the mammoprint doesn't have a sufficient data set to give you an answer. It's actually only clearly indicated in women with stage 1, stage 2 disease. So it doesn't address all the questions, but it sits in the space where we have a problem. The Oncotype DX, much more widely used in the US, but is growing in Europe and the Middle East, is actually only really valid in ER-positive patients. That's where it was derived. The presumption being in ER-negative, we can use other things to choose when to give and when not to give chemotherapy. But again, Oncotype DX was derived in patients who were ER-positive and treated with tamoxifen. Postmenopausal women nowadays are mostly treated with AIs. So again, we have to be slightly careful about how we take that information into the clinic. And there are 2 others on the right which are less widely available, less well validated, and have slightly narrower inclusion criteria. One of the questions raised is, do the genomic signatures tell us more than just proliferation? So the first thing is, this is a paper from the New England Journal some years ago looking at a number of different predictors applied to the same cases. They had very few genes in common, but they all gave the same powerful prognostication. They could split a good prognosis from a poor prognosis group. But even the good prognosis group still had around a 10% recurrence rate. It's not yet pulling out patients with 0%. So it gives you a guide, but it's not perfect. And interesting enough, if you look at the genes involved, and this is a slide from Christos Sotirio, who was here last year, actually there are a number of different biological processes pulled out. And taking the Amsterdam and Rotterdam signatures that were developed both in Holland, they had very few genes in common, but around 30 to 40% of the genes were proliferation. The rest represented other pathways. And if you look at this cartoon from Nature about 10 years ago as the sort of metastatic cascade, starting in the top left with tumour cell growth and the whole process of invasion and metastasis, you can map onto this whole process the genes that are used in genomic signatures, from the top right down to the bottom. So the genomic signatures have a strong component of proliferation, but do represent a number of other biological processes. Interestingly, all of them tend to have their strongest prognostication in the first 5 years. Now that's important. Partly it's how they're derived, because they're derived from follow-up, and we lose patients to follow-up the longer out we go. But it's also important because we currently want to use them around the chemotherapy question. And if you look at the Oxford overview curves, where the curves separate in chemotherapy versus no chemotherapy patients tends to be in the first 5 years. So whether by design or by chance, because the genomic signatures have their most powerful effect in the first 5 years, and that's where chemo has its effect, they are actually quite good at addressing that question. What they're not yet capable of doing is saying which chemotherapy, and nor are most of these signatures much good at saying, well, who's going to relapse in 10 or 15 years' time? Other groups have started to look at signatures there, and different biological processes come out. So we have to remember what they're designed to do and how we should use them. And it's really around the chemotherapy question that they probably have the most evidence. But you still need your pathologist. They will not replace your pathologist. And so if you look within the groups of whether patients are treated or not treated, classic, standard, clinical pathological criteria like size, like node positivity, still drive prognosis. And the interesting thing about the genomic signatures is they seem to have the same sort of separation in both node negative and node positive patients. And clearly a node positive patient with a high risk signature is at much higher risk than a node negative patient with a high risk signature. So it's not replacing pathology, it's adding to it. The two most widely used as far as I can understand, and I think the two that have got the most validated data are the MammaPrint, derived in the NKI in Holland, and Oncotype DX. There are two issues around any signature you wish to use. One is the technical validation, which is if you get a result today, will you get the same result tomorrow, next week, and next year on the same cancer? The second validation question is, what does that information tell you? Will it consistently give you the same clinical guidance? For MammaPrint, the technical validation is good, but it has to be done in experienced labs. Whereas the clinical validation is not so strong, and that's of course driven the trial called MINDACT, whose data we await. Oncotype DX is done in one laboratory, so you don't have quite the same technical validation issues. It's almost certainly, because it's done in the same place consistently, it's very good. But equally, its clinical validation as a tool to select or not select for chemotherapy, it's stronger than MammaPrint, because there's a bit more data. But it's still not strong enough, hence the TAILOR-X trial. So my own personal view is that for routine use in every patient, are these tests ready? No. But, and the but is that they add additional information. So if we go back to that same patient where we really don't know what to do, let's go through some examples of what the genomics might tell you and how we would respond. So you can get quantitative measures of ER, PR, and HER2, not just yes, no. And that will, of course, as these are biological continua, influence what we do. So let's take someone who has a genomic grade 1 cancer, quantitatively high ER, PR, but absent HER2. MammaPrint says they're low risk. Oncotype says they're low risk. Who wants to give that woman chemotherapy? She clearly has an endocrine-sensitive, low-risk cancer. And so the genomics can add into your classic pathological data and say, I can safely avoid giving this woman chemotherapy. Her risk of recurrence without chemotherapy is low enough, and the hormone sensitivity is good enough to avoid chemo. But the genomics could, of course, reverse that. With the same pathology data, you could come out with a GGI grade 3 and or MammaPrint high risk or Oncotype DX intermediate high risk. We've suddenly got a very different picture from the same pathology data. And in that setting, I would give this woman chemotherapy followed by hormone therapy. So it can help discriminate these difficult grey cases. The risk is, of course, particularly with Oncotype DX, you can end up back in the middle with an intermediate risk. And again, it's an indication that we as clinicians sometimes want a yes or a no answer. And the grey in the middle is what causes us the challenge. The challenge, of course, is if a genomic test disagrees with your pathologist and says, actually, I'm sorry, this is a triple negative high-risk patient. So we'd give her the chemotherapy because she's high risk, and then we would not give the hormones. And I guess as clinicians, would you trust the genomic assay more than your pathologist's ER-PR score and decide not to give her the hormones? That's a brave step to avoid giving something. I'm not even sure what I know my own answer would be. I guess I'd make my pathologist redo the tests. And finally, and this touches on something in the previous talks, what if this woman is a HER2 positive cancer? Not HER2 negative as we thought, but low risk. We're going to give her hormones, but when are we going to get the data to allow us to give anti-HER2 without chemotherapy? And I think the other thing that genomics might allow us to do is to better interrogate the biology of these cancers and start to look for a more targeted therapy. This is not what I would do in the clinic, but this is a benefit of a genomic approach, giving us richer data and posing more complex questions. So in summary, we need better diagnostics because we need to make decisions for our patients. We have to respect that the pathologists do their best, and the challenge is around cancer heterogeneity, both within and between patients, and the fact that we give our pathologists a small sample and we actually want an average effect. The second challenge is, are we always measuring what matters? And I think some of the advantages of genomics is that it measures a number of biological pathways, particularly around the metastatic process, which is actually what we're addressing. If our patient had no metastases, we wouldn't be giving adjuvant therapy. And so it's going to be a question of combining your best pathology with the new genomic tests as they emerge, I do not think we should use these tests in every patient. They have a place in those patients in the middle where there is a clear therapeutic uncertainty, and actually they may help sort out which patients really do need, for example, additional chemotherapy and which ones don't. Thank you.
Professor David, thank you very much for this very nice how science can help the patient nowadays and in the future. And urgent question from Dr. طاهر التويجري. تفضل يا دكتور. Okay. I have some notes from the organizer. Please shut off your mobile phones, and please, to the speaker, next speaker, include myself, stick to the time. This is not from organizer.
Dr. David Cameron, I would like to thank you for this very excellent talk, which is applicable to our region. Because the concordance here in this region, at least where I am working, is about, ER, PR, and HER2. The difference between positivity and negativity is about 60%. Ooh. And I'm challenging all the audience here who's working at any institute to look at that. You put one of the slides that in the United States there is errors. And the error in the United States, because these centers are not CAP accredited, and I know that. And in the same time, a lot of centers in Europe, because they are not CAP accredited, the reason for that, making a lot of errors, so we don't know where is the right and where is the wrong. So giving the fact of that, because I am from a place where we are CAP accredited, and we are following on this every 3 months, we know that we have also problem, even with the CAP accreditation, the American pathology. So basically, I tell you that what you are saying is right. The other thing is that I have extensive experience with the Oncotype DX, and we know that in our region, however, our young patient, we have 75% who are low risk, which is, as you said today, and thank you for that, that that whatever the tumor size, but ER positive and HER2 negative, not negative, whatever the Ki-67, whatever the grade, we have about 75% of our patient population are low risk. And I'm announcing this today because this is very important that we are giving only tamoxifen. I agree with you, the majority of our patients are premenopausal, not that much of postmenopausal, yep. So we are giving tamoxifen. It's true. The question, how we are going to shift from tamoxifen to aromatase inhibitor, this is another issue. But again, even in the United States, still a lot of centers that they are not CAP accredited, they are no follower, so that means that it is not the best lab in the world, it is there. It is not right. Thank you very much.
Thank you. Now, I think it's very important that pathology labs can take part in these kind of ring accreditation systems, because we all need to know that they are as accurate as possible. And that's important. Thank you.
Before moving, we have to thank Professor Cameron. And we have to move, and I have actually the pleasure to introduce one of my dearest friends, Professor Marwan Ghosn from Lebanon. He is a professor and chairman of the Hematology Oncology Department, St. Joseph University. He is the editor-in-chief of the PAJO, which is the Pan-Arab Journal of Oncology, and he was actually the president of the